I'm really thrilled to introduce our last panel on best practices in small nursing homes. As you've heard, we have Robert Jenkins from Jenkens Consulting, but who has been a leader in this space since its earliest days, beginning, I think, with the Robert Wood Johnson Foundation. And the session will be moderated by Laurie Facciarossa Brewer, a very busy woman, and especially busy over the last 3 years. Our terrific New Jersey Long-Term Care Ombudsman, who I like to call Ombudswoman. Laurie was named the Long-Term Care Ombudsman by Governor Phil Murphy in March of 2019. In this capacity, she heads the New Jersey office of the State Long-Term Care Ombudsman, which advocates for residents of long-term care facilities by investigating allegations of abuse, neglect, and exploitation. The Long-Term Care Ombudsman also supports policy and legislative initiatives that foster the rights, dignity, and self-determination of individuals living in long-term care settings, and in this role has been a terrific partner and advocate for consumers in our long-term care facilities. Laurie has helped advance legislation to reform the state's long-term care system in the wake of COVID-19. Public health emergency, successfully lobbied for a Bill of Rights for LGBTQI and HIV plus residents of long-term care, and created a federally funded social isolation project designed to address the needs of residents of long-term care facilities hardest hit by the COVID-19 crisis. Prior to being appointed ombudsman, Laurie served as the Long-Term Care Ombudsman's Chief of Staff for 9 years. In this position, she oversaw a dramatic increase in the Ombudsman's Volunteer Advocate Program, obtained federal funding to help transition people out of nursing homes, and streamlined the Ombudsman's intake and investigation process to improve response times. A former newspaper reporter, she has more than 25 years of experience in state government and nonprofit sectors. She is a graduate of Rowan University and has served in several senior management positions in New Jersey state government, including Director of Communications for the New Jersey Department of the Public Advocate, Director of Public Affairs for the New Jersey Department of Human Services, and Deputy Project Manager for Healthcare Reform in the Department of Human Services Division of Medical and Health Services, or Medicaid. So we're thrilled to have Laurie with us. Thank you so much for moderating today's panel and introducing Robert to us. Thank you.
Is this working? Can you hear me? That bio was way too short. I feel like a total loser now, Angela. Thanks so much for inviting me to moderate this panel. This is a topic that's very close to my heart. As you mentioned, I'm on the task force for long-term care quality and safety, which is going to be a blueprint to reform the long-term care system. And this was one of the first conversations that we had. I'm looking at Stephanie where she is, but this always comes up. You don't talk about reforming the system without talking about the greenhouse or the small home model. And we have a very revered expert on this here with us today in Robert Jenkins. So I'm going to read his bio now. Robert Jenkins provides policy development and operational consulting to assist policymakers, advocates, and providers implement and expand access to high-quality, person-centered long-term supports and services. Robert focuses on proven innovations in home and community-based services, affordable housing with services, and skilled care that serve people with low and moderate incomes. Prior to his current consulting work, Robert was the Director of Social Impact Initiatives at the National Cooperative Bank, Managing Director for Aging and Independence and Capital Impact Partners, Director of the Robert Wood Johnson Foundation's Greenhouse Project, Coming Home Program, Development Director for Assisted Living Concepts, and a Senior Analyst for the AARP's Public Policy Institute. Robert received a Bachelor of Architecture from Cornell University, a Master of Science in Real Estate Development from the Massachusetts Institute of Technology, and studied public policy at Harvard University. Robert serves on the board of several national and community nonprofits focused on healthy aging, long-term supports and services, and affordable housing. Robert was a founding board member of the Center for Excellence in Assisted Living and continues to serve on its advisory council. Selected awards include Dick Ladd Award for exemplary work in aging, the GE Healthcare Finance Award, and the AARP Legislation and Public Policy Achievement Award. I think that deserves a round of applause. Welcome, Robert, and thanks so much for coming to here in New Jersey to talk to us today. I'm just going to turn it over to you because I think maybe you can, instead of going right into questions, you want to go into your slides and okay, start your presentation.
Thank you, Laurie. So I think I will probably repeat a lot of what Susan and Rebecca have covered, but I think it's worth repeating some of the key points, and then particularly addressing the question that was asked at the end of Rebecca's session about small home projects that have not worked out. So I'll try to cover all of those pieces. I'm going to talk a little bit about, just to review, the core elements of the greenhouse model, so the physical and the operational side, the financial results that we saw in the program and research while I was involved with the program, and then what is needed to encourage more greenhouse and small house homes to be developed in New Jersey and across the country. So the first slide is really just to remind us that the greenhouse model does rely on a very specific physical environment to both create a home, but most importantly for this conversation, to create an efficiently operating home that costs no more to operate than a traditional nursing home. Now, that's not to say that the physical environment doesn't cost something to create, but once it is created, it then operates at the same costs. Rebecca mentioned in her organization a little bit less actually than the traditional nursing home. And that's because of the staffing and the staffing efficiencies that go with that. From the resident's perspective, it's really about creating the warm home that Rebecca spoke so well about. And not just for the resident, but for their family. So when I was directing the greenhouse project, the initial phase of the greenhouse project, walking into Rebecca's greenhouse homes, walking into others, and finding families so comfortably spending time with their parent, with their aunt or uncle, and not looking at their watch to figure out when they could possibly leave at the soonest moment. I wanted to tell one story on Rebecca's project, which is one of my favorite greenhouse stories. So when they were just getting ready to open, they were a little behind because of the life safety issues that Rebecca mentioned. So they were anxious to get open, and they had a sort of a very tight window before residents were going to move in. And one of the last things they were waiting for was the mattress company to deliver the beds. And Rebecca, I don't know if you remember this story. So they knew that the mattress company was coming between 9 and 11. I think we're all familiar with this story. And it didn't come. It was 11 o'clock, came and went. Finally, somebody called the mattress company, and they said, well, where's the truck? You know, we need 10 mattresses per house, 2 houses, 3 houses. And they said, oh yeah, the driver has been looking for your nursing home for hours. And he pulled up outside the address you gave us, but that's just a house. So he went away. So to me, that was a good early indication. Next slide, please. So on the physical environment, we've talked about this, and I think it goes to the question about building in dense urban neighborhoods. The core belief in the greenhouse is that you build to replicate the housing that's familiar in the community. So if you're in rural Iowa, what's familiar is a single-family home. If you're in suburban New Jersey, it's a mix of single-family homes, mid-rise apartment buildings, and some high-rises. If you're in New York City or Chelsea, Massachusetts, it's a high-rise. What distinguishes the greenhouse when it's built as a high-rise is that you walk as Rebecca mentioned, you go up the elevator and you come into a lobby. You don't walk right into somebody's bedroom. You come into that lobby and then you knock on the front door of what's an apartment for 10 people with a front door. You walk into the front door, there's a vestibule, there's a living room, dining room, and kitchen, and then the bedrooms are beyond that, just the way they would be in your own home. So people who are skeptical about the greenhouse model will often say, well, you can't build this in an urban area, you can't build this in some place that has expensive construction costs. The houses, the single-family houses cost less to build while they still meet the same nursing home life safety standards as you would expect than what it would cost to build a traditional nursing home, because the construction method to get to that life safety standard is less expensive when it's small. In an urban area, it's going to cost you the same amount to build a greenhouse as a traditional nursing home, with the understanding that you're building private bedrooms. So there will be some more square footage than what a typical nursing home would have with double occupancy rooms. But as Susan mentioned, we don't really want double occupancy rooms anymore. It's not a safe environment. So just the key points: familiar residential housing type in the community, small homes, 10 to 12 people typically, all private bedrooms and bathrooms, open kitchen. That is a key operating efficiency. If you can have the direct care staff working throughout the day at different tasks so that you're using them at 100% efficiency, then your operating costs, your staff costs are going to be less. Also bringing down that management structure, which is the expensive salaries, and plowing that money into better salaries for direct care workers and more time. There's about 30 minutes more direct care time on average per resident in the greenhouse homes compared to matched traditional nursing homes. And then the most important thing I think to remember is the small house is necessary for the success of the greenhouse project, but it is not sufficient. And it's the operating piece that really is the magic, the secret ingredient of the success of the greenhouse homes. And I wanted to mention that in the context of the question that was asked at the end of last session. There are many people who build small houses. They've been very touched by what they see in the greenhouse, but they don't change their operating model. And if you don't change your operating model, you will die financially. It will be more expensive to operate a traditional nursing home disaggregated across, say, 10 small homes. I saw this when I was the director of the project. We were asked to come in and save a project that had been inspired by the greenhouse but didn't want to join, didn't want to do all of what the greenhouse required in the transformation. And they literally bled to death financially within 2 years. And that was with very good occupancy because people wanted to live there. So you have to do both to be successful. And it's important not to be confused when people say, well, we had a greenhouse and it failed. They most likely did not have a greenhouse. It was probably something they thought was a greenhouse, but they hadn't done the harder work of changing the operations. Next slide, please. So the core elements of the operations, and I think Rebecca and Susan covered these, but major operational redesign. And that's essentially disaggregating or disassembling the very rigid departmental structure of traditional nursing homes and putting that back into that direct care team with the supervision that Rebecca mentioned, where the Shabazim, the direct care workers, are all responsible for some of the quality control and management of the different aspects of the house. Self-managed work team is, I think, the secret to the staff retention and the success of the project. You put power and value into the direct care workers who have not had that. Research is very clear that the staff turnover is related to not just compensation, but the value and the inclusion that direct care workers do not get in traditional settings, and they do get in the greenhouse model. The houses need to operate autonomously at the direct care level. If you try to manage them as a whole and kind of the old assembly line approach to nursing homes, your financial model will not succeed. And then, as I mentioned, the secret sauce really is the operational success, the financial success of the greenhouse model. And you need all of these elements to get the results. You cannot do this in an a la carte model. So as was mentioned earlier, there are other good models of culture change, and the Greenhouse Project supports all of those. But it's important that it's a model, and it's a cohesive, evidence-based, and research-proven model, because taking a little bit from here and a little bit from there, an a la carte approach is really what we saw fail when we were watching others who were trying to do similar things. Next slide, please. So for the financial results, I know this is much on people's minds. So the greenhouse, so we conducted a fair amount of research under the Robert Wood Johnson funded grant, and really studied the financials of the early projects that were built. So, probably 30 projects at the time, so 30 organizations with multiple houses each at the time of the research. And what the research found was that the streamlined management, pulling money out of department heads and assistant department heads and putting that into the greenhouse homes, allowed the operating costs to be the same, in some cases a little bit less, in some cases a little bit more. The reason for that was there were no more total staff hours. The staff hours were the same, but as Rebecca mentioned, they shifted to the direct care away from the departments. The operational costs, we found that the median resident costs per day were within 1% of the matched traditional nursing homes that we had in our study. And that if you then compared those to nursing homes overall, they were about 7.6% higher than the mean, which means that they were in the 60th percentile. So we're right about in the middle of operating costs for nursing homes. And for that price, we got all of the results that Susan talked about in the research. So better staff satisfaction, better resident satisfaction, better family satisfaction. And then most importantly, although the greenhouse model was not designed for a pandemic, most importantly for the last 3 years, the fact that we had fewer infections and then many fewer deaths because of the staffing, the clinical model. Clinical model is important to recognize. There is still significant supervision on the clinical side from the director of nursing, from the department of nursing. So we don't change the clinical model of skilled nursing home. We change really the day-to-day operating model. Next slide, please. So there's a research article available on the greenhouse website from the research that we conducted. The mean occupancy is a big piece of the financial success of the greenhouse homes. It was 96% at the time of the research compared to what at that time was 88% across the United States. That difference of 8 percentage points makes an enormous impact on what you can afford to build, what debt you can afford to pay, and then the profits that you can pay to your shareholders, because as we know, most nursing homes are for-profit across the United States. The capital costs are significant to build a greenhouse home. When we were building them, they were about $1 million per house for 10 people in Arkansas. They were probably about $2.5 million in New Jersey. So big difference in New Jersey. New Jersey is expensive, as we've recognized. The Arkansas model that I referenced earlier in answer to a question, the state pays $10 more a day for greenhouse homes, or at least it did in 2011, to cover the capital costs, not to cover higher operating costs, but simply to allow that project to build the new homes and cover the debt that those new homes required. I believe we need to significantly renovate or rebuild nursing homes across the country to avoid the outcomes of the pandemic that we've just experienced. So we're going to be putting money into the capital side of nursing homes. We might as well put it into a model we know works well to resist the ravages of the pandemic. Next slide, please. Additionally, some financial results. So we know that the model is working because we have 371 homes open across about 62 organizations. We know that the most recent results, which are extraordinary given the pandemic, is that the greenhouse occupancy in 2021 was 25% higher than the U.S. average. The greenhouse occupancy increased during the pandemic. Now, this was not a typical occurrence for nursing homes during the pandemic. So as traditional nursing homes lost occupancy, greenhouses gained occupancy. So I think that's the market telling us this is a model people want and a model people trust. The staff turnover is another huge piece of the financial success. So 75% less staff turnover at the CNA level in greenhouse homes, 65% less for LPNs compared to traditional nursing homes, and 55% less for RNs. So huge costs in addition to the quality impact that staff turnover incurs. Next slide, please. So what is holding us back? What is holding back building more of these greenhouse homes? So we're not building a lot of new nursing homes, but we probably need to deal with what we've been through in the last 3 years. Medicaid rates don't recognize the capital costs, so we need to have an add-on to handle the new capital costs. Or we can provide grant funding up front, but that's a much bigger hit for the state. Scaling the small homes cannot rely on charitable giving. That's how we built the first greenhouse homes. We had huge fund drives by the organizations that were interested in building them. There is not enough charitable giving to go around to make that happen. We had the Hill-Burton Act to build nursing homes in the first place. We need either another Hill-Burton Act, or we have to have rates that will simply pay providers enough to afford the debt service that they will need to incur. And then the final thing, and I think this is important to know, and certainly we've seen this in greenhouse homes, the culture in nursing homes is very conservative. Nursing homes have to deal with a lot of regulation. They've been sort of a self-selected group of people who are comfortable with the model that's currently in place. So it's hard to change that. But the one way that I've seen very effective to change that is to provide the financial incentives to the people who own and lead nursing homes to rebuild and to go through the hard work of creating a new model. So we need to provide people with the rewards, both at the staff level and at the leadership and ownership level, to make this happen. And that's fair and that's appropriate. And then finally, how do we move forward from here? We need a new tool. We have seen what our old tool provides. And we knew before the pandemic that it didn't give people the quality of life that they wanted. The AARP's research consistently shows 88 or 90% of people saying they don't ever want to live in a nursing home. So nursing home providers need a new tool to deliver the quality that they want. And we, I think, as a society want that. We can create grants. We probably need low-interest loan pools. We need funding for the training, as I think Rebecca mentioned. But most importantly, we need that consistent rate add-on so that people can finance the capital side to get themselves going. And we need meaningful financial bonuses to people who are delivering the quality of care that we're looking for, which the greenhouse is one tool to do, to inspire the markets to turn toward this. We also need to make, as Rebecca mentioned, the construction and licensing process a little simpler. My experience when I was directing the greenhouse project is you really needed a superhero to get through this. We don't have enough superheroes to convert every nursing home in the country. So we need to make this an easier process for people like us who just want to do the right thing. And then I think the final question is, how do we justify the extra costs? We know we're going to have to spend some of this money to begin with. We know we can't keep doing what we've been doing and expect different results. And it's quite possible that greenhouse homes, even with the capital conversion, will be less expensive than trying to keep an old model going in the age of pandemics. I just bought a new car after 14 years. And I bought that car not because I wanted a new car, but because I realized I couldn't afford to keep the old car. And I think that's where we are. So let me turn it back to you, Laurie.
Thanks so much. Does anybody have any questions for Robert? I figured there are going to be a lot. So the first hand I saw was the lady in the back who's getting the microphone. Sorry, Susan.
Hi. I just wanted to ask, you had on the slide that 62%, of traditional nursing homes are Medicaid paid recipients. Does the greenhouse model need to have a better balance to succeed? Because another presenter had said that share was 50%. And the other question I have is, are the existing greenhouse homes, will they take people direct on Medicaid? Because we know in New Jersey, even a lot of the nonprofit nursing homes require people to have 2 or even more years worth saved up. So can you explain like how the model works between private pay and Medicaid?
I think that's actually assisted living that requires a couple of years private pay.
No, I think that's true of some of the nursing homes in
Wow.
Bergen County. Where I live.
Medicaid, CMS certified nursing homes?
Yeah.
I would like to know about that because I would
Okay.
investigate that.
Okay, I'm happy to talk to you about that.
But it's an excellent question. So it really does come down to how projects can handle their capital costs. If a nonprofit is able to fundraise for the majority of the capital costs, so they have no debt on their building, then they can accept the same ratio of Medicaid that they have in their traditional nursing home, and that's usually around 60 to 70%, because they don't have that extra capital cost to try to pay. If they finance the project, they have additional debt service, and they typically have to have more private pay than what they would generally have in their traditional home to make that work financially. And certainly if you're a for-profit, you're going to want to get some bump in your margin for that work.
Yeah, I would add also, I believe some of them have short-term
Yes.
rehab.
Yes. So yes.
So can you talk about what that looks like in the
Sure.
in the greenhouse model?
Yep, absolutely. So the short term is obviously a profit center for all nursing homes, for-profit and non-for-profit. Greenhouse homes have proven to be an exceptional environment for short-term rehab, that you set aside a home because you don't want a lot of people cycling through a long-term greenhouse, but you create rehab greenhouses, and then for people who've been in the long-term greenhouse, and they can come back and get their rehab there. But the consumer response to the small scale, the cooking in the house, the individualized cooking, we had a question about culture as well. And I think one of the great things about a small scale home is that you can respond to the individual people in the house. And if that happens to be all from a singular culture, you can certainly do that. So if it's a disease culture or a community culture. But you can also then, if you have a house with mixed cultures in it, those cultures can be shared. So maybe one night there's food that's somebody's family recipe from their traditional Lithuanian grandmother. And maybe the next night there's something that is created because someone is from, ancestry is from Cuba. So you can really create the culture and the scale around those small homes. And I just wanted to make that point based on a
I just
previous
want to
question.
follow up on the rehab. What about often in nursing homes and rehabs, there's a big room
Yes.
where there's all kinds of equipment and space to do physical therapy. How do you address that in a small home environment?
It's a really wonderful question, and Rebecca may have more to say about this as well. So our experience was twofold. So all of our nursing homes had rehab gyms. So if you were rehabbing at home, typically you either have a rehab person come to your house, a physical therapist, and you use the equipment in the house. Might be a small piece of equipment the PT person brings with them, but more likely it's that they will work with you to figure out how to get in and out of bed and on and off the toilet and in and out of a chair. And of course, every greenhouse has toilets, chairs, and beds. Or you go to a rehab gym. And so in the greenhouse, you might have gone from your home to the gym that's on campus, the rehab gym. So if you needed specialized equipment or a bigger space to do that.
They do have that. Okay, thanks. Other questions? Susan. I think Susan was.
Who's somebody else? All right. So I guess I'm feeling a little competitive with Arkansas, and really intrigued that they're now building 17 on top of what they've already have. So I'm kind of curious. I'd love it if you could drill down a little bit in terms of how that environment was created in Arkansas that has really allowed for that level of development, including, was the rate determined by the legislature? Was that something that was done through the regulatory process, a waiver? But how is it that they've been able to advance so far? past New Jersey?
Sure. An excellent question, Ev. So Arkansas had this really delightful convergence between a woman at the Department of Health who was a real believer in the greenhouse model and also was the head of licensing, and a real advocate for the model. We had an extraordinarily entrepreneurial for-profit developer who recognized that Arkansas was ripe for redevelopment. There were so many nursing homes that you couldn't believe were actually still standing. So he bought those at a very low price, tore them down, and was able to rebuild at a low cost, but not low enough that he didn't need a $10 a day rate add-on to handle the new construction. And he was a very persuasive fellow. He's now on the board of the Greenhouse Project, a man named John Ponte, a true believer in improving the quality of life and quality of care as a for-profit nursing home operator. And then you have a legislature in Arkansas that's pretty responsive to the nursing home industry in the state. And so he was able, working with the Department of Health, to convince the legislature that they should provide this just second category of nursing home compensation that was $10 a day more for people who both created the houses, but then also importantly implemented the operational design of the greenhouse model.
And Robert, he built his operating model on all Medicaid. So he has an operating model that takes into account, I'm only going to get Medicaid reimbursement. And as he says, when I get people privately paying, it's more money in my pocket. So it can be done.
Yep. And I think that's worth following up on. So you can either build your building for free because you have so much charitable donation to do that. And we see in Chelsea, Massachusetts, it's largely a Medicaid-funded project, and they did that because they had such strong financial support, which it turns out it came from a casino magnate. So if you have casino magnates still in New Jersey, maybe that's one way to fund.
Get enough of my money, I know that.
But then, as Rebecca points out, in Arkansas, a for-profit, very sort of business-focused nursing home operator and developer was able to meet his goals, his margin. He returns 10% margin to his investors. He expects a 10% margin. And he was able to do that because of the ongoing daily rate add-on. So lots of ways to get to the 100%, 90%, 80% Medicaid. And that's important because private pay customers don't exist in all markets. So in a low-income community, which has really been the basis of my work, you cannot expect that you're going to have 20, 30, 40%, 50% private pay. You have to solve this for a 100%, 80%, 90% Medicaid model.
So did Arkansas have certificate of need?
They do, and thank you, Susan. That's a really critical piece of this. Not every nursing home provider wants to build a new model. A lot of nursing home providers are comfortable with the models that they grew up with, and they're comfortable with continuing that model until they can no longer do it or until they retire. The trouble with CONs is they give that nursing home provider not only the power to not change himself, but they give him or her the power not to change for the community that relies on them. So you do need the state to provide CONs outside of the regular process to people who are willing to implement a new and proven model. And when I say proven, I really mean evidence-based and research proven. So we saw that in Massachusetts for the Chelsea nursing home conversion. They would never have been able to do it without that. They were over-bedded by traditional CON calculations and standards. We've seen many nursing home, many people interested in creating greenhouse homes stopped and stymied by not being able to get a CON and having the nursing home in their rural community not interested in adopting the greenhouse. So we do need to take away this free market constraint, which is sort of extraordinary to me that we've lived with as long as we have, and allow the markets to help the industry into this new path and new era. So great question, Susan. Thank you.
Well, did they have certificate of need? Did they have to do something?
They did.
They did. So
but because John was able to buy existing nursing homes, he
the
did.
certificate of need.
So, and because they were inexpensive enough to buy, because they were in bad shape, he was able to afford to build that into his development costs, and that was covered by the $10 a day rate add-on. Yeah.
There's a question back there.
Yeah, thank you. I'm focusing on what you said about how the provider must adopt the operations model in order for the greenhouse to be successful. And I know you've talked about capital construction costs, but in New Jersey, we have regulations for our nursing home providers that exceed CMS requirements.
Sure.
So have you done a study in New Jersey to see, under our current regulatory structure, staffing requirements and others, is it possible under our current regulatory structure to build a greenhouse, even if you meet the expectations of the capital cost through increased reimbursement under our present regulatory system, and have that each of those homes be able to operate autonomously, like I think I understand you said, for them to be successful, and why some homes in some states haven't worked out?
Sure. That's a great question. So we haven't done a specific study in New Jersey, but we did have a project in New Jersey, Green Hill, that was able to build and operate within the constraints of the New Jersey system, and successfully financially. And that has been true for every state that we've gone into. And very often we get a similar question. Our state has X, and that's different from most states. Will this work? So if traditional I think the easiest answer is, if traditional nursing homes work in your state, given the requirements, Greenhouse doesn't do anything to change the regulatory requirements of a nursing home. We meet every single state and federal requirement for nursing homes staffing, clinical services, administrative staff, and credentials. We just rearrange the day-to-day operation of those people, and because we can create more efficient operations within the house and remove some of the departmental structure and some of the ancillary costs associated with that, that cost shifts allows us to operate at an even operating level. So I would have no reason to believe that there is anything impeding rapid greenhouse development in New Jersey. It didn't stop Green Hill, and I didn't see it stop any other provider interested. Now, that doesn't mean that there weren't extraordinarily hair-raising moments in the discussions with licensing staff, with regulatory staff during some of the first surveys. Rebecca can probably speak very eloquently to that, because we do change the way we meet those regulations. We meet all the regulations, but surveyors particularly are used to seeing regulations met in a certain way. Mm-hmm. And they sometimes have challenges transitioning to see that we're still meeting the rules, but we're doing it in a different way. So I think part of the training that needs to happen in a state is with the surveyors, with certainly the ombudsmen who are out in the field, to understand what to look for and how to understand a different model meeting the same rules.
So you
great
don't
question.
have to have unless Jim wants to follow up, what specific positions? So do you have like an administrator, a director of nursing, an assistant director of nursing, a director of social work? Do you have all of this typical things that you have in a nursing home?
Absolutely, and most of those are required by rules. What we don't have is sort of the middle management of laundry, food service, housekeeping, activities. So those are all what gets built into the self-managed team with support from their coach. So you have an administrator over the whole project, but then you have coaches for each of the houses. And those coaches are like assistant administrators, mm-hmm. but they have a very different approach because they need to be able to coach a self-managed team.
Thanks for that. I see.
Institutional or community-based?
Well, I consider them community care, but they are licensed as institutional care. And one thing we would love to do, and maybe New Jersey could be a leader in this, is, and this was true for Rebecca's project, We would love to see a 120-person nursing home converted into 10, 12 greenhouses, but not have those greenhouses have to be on the same campus. We would love to see them embedded on a residential street next to neighbors with kids and grandparents and single people coming just out of college to work, so they can be part of a natural and normal community. Now, campuses are good. You know, a lot of older people decide they want to move into a 55 and older community, but many of us don't want to live on a campus with only people who look and feel like us. So being able to have something licensed as a 120-bed nursing home, but divided into 10 houses spread across 4 communities within the market area of that nursing home would be my next step in innovation.
Yeah, interesting. Thank you.
My question is, thanks so much for all that you provided and for this session. Is there a toolkit that you have to take to state regulators and legislators to educate people about the needs of what this model is and what kind of changes or simplifications in process that would enable developers to want to go into this? Do you
Sure.
have it in different states, or especially something focused that would be helpful in New Jersey?
Yes. I'm going to let Rebecca speak to the specifics of how the Greenhouse Project helps and handles that now. What I can tell you, when I was part of the Greenhouse Project, when we were going into a new state, we sat down with that state's licensing agency and went through the entire model and explained how we met the state's specific rules. And that was very helpful. So once you have a greenhouse, that's happened. But let me let Rebecca address how it happens today.
Yeah, that's a great, we still do that, but it requires a provider to say, hey, we want to partner with the project to kind of do that. So the other thing that we have is a regulatory survey for general providers to say, how do you build allyship within your legislator? What are you asking for, and how do you do it in a successful way? So there's a great webinar, and then there's a nice little toolkit alongside. I'll make sure that it gets to the AARP. Thank you.
And Rebecca, let me give you a chance right now to correct any of the things that I've not said correctly or haven't kept up with.
Robert has done a beautiful job. He was the director of the Greenhouse Project when I was an operator, so it's nice to see old friends again. The only thing that, just for clarification, but I think I drove that point pretty home, is that the house structure has become a lot more flexible with the Greenhouse Project. And the reason that it's become more flexible in the last couple of years is for 3 reasons. One is because the pandemic has pushed the organization to say we need to help more elders. How do we support more organizations? The other thing is the project merged with the Pioneer Network. So to look at data and evidence-based initiatives beyond a small home with all of those models has become a little bit more realistic. So again, we really value small, but we can see it be successful as long as you keep those staffing ratios consistent. So thank you.
Yep. And I think that's a good point to drive home even further. So we saw several successful implementations of greenhouse homes in a renovated wing of a traditional nursing home. It was a big renovation. You know, you had to create a front door, you had to create the open living room, dining room, and kitchen. So it was essentially a gut of the wing. But in some areas of very dense areas of New Jersey with high construction costs, that may be a more economical way to do it than to try to tear down a building and rebuild. And it certainly makes a gradual transition a little easier.
For people who are cost per square foot immaterial, let's just imagine this is all free for a second. Given where we're at right now, what kind of financial instruments are getting new projects built in the current environment? One with the federal reimbursements being where they are at, and also with the changes in interest rates.
Yeah, so Rebecca may have more immediate information than I have since I've been gone from the project for a number of years. When I was directing the project, the way projects were being built, because it was an innovation and it was typically innovative organizations who were most often not-for-profits, the way they built buildings was that they raised the money to build the structure. Occasionally, they took on a small amount of debt that they felt they could handle under their Medicaid and private pay mix. but they were generally building with free money, whether it was grants from outside organizations or through a charity fund drive. As I mentioned, John Ponte in Arkansas was able to finance his new construction because of the rate add-on. So he had investors who provided the equity side, and then he took on debt to build those. John has also used a tool that's a very good tool, a little complicated, the new markets tax credits. So traditional housing tax credits cannot be applied to a greenhouse because it is an institutional use, and low-income housing tax credits cannot be used for that. But new markets tax credits are for economic development and business uses, and they can be used. And they create a very affordable interest rate because of the tax benefits to the investors. Yeah. Rebecca, anything more current than that?
I wish there was. USDA has been a viable entity that's driven a lot of change. Unfortunately, I think it has to start with legislators saying to providers in their respective states, we will compensate you differently for this, or we will alleviate other barriers, either operationally within the staffing model, or, what was I going to say? Through code, through construction code, so that it perhaps can be a hybrid of PACE where it's a non-certified building with a certified product, if you will. So I think those are the innovations that we're starting to see movement with. But it starts with a government saying we'll support you, or we'd like you to go this way, and here's how we're going to do it.
I just have a quick question. You talked about wanting to integrate these into communities.
Yes.
Would be your druthers going forward. Is there any community resistance at all? Because you have zoning rules, you have construction codes. This would come under different zoning rules,
Yes.
I would think.
So we often talk about the two certainties in life. I would add a third, and community resistance would be the third thing we can count on. So yes, so you would need to find the right site. You'd have to find the right community. But I do think if you had a community that you were interested in building these in, and you took them to Rebecca's project in Rochester, that would alleviate 90% of the concerns. They are a house in the community. They're probably a little bit bigger than most houses in communities, but they look like a house. They feel like a house. They don't have, they don't have all the institutional trappings. They don't have the huge trucks coming to deliver to them. So they would work in a community, but I think you would have to be sensitive to exactly how they're placed in that community. And it's a good question. Yes.
My name's Althea Pestine-Stevens, and I'm here with my colleague Lauren Snedeker from the Rutgers School of Social Work. I really appreciate all of this conversation about the policy infrastructure pieces that is going to be so important for moving this forward. But I'm kind of thinking, going back to the previous panel about workforce considerations, especially, considering our, role at Rutgers School of Social Work, training social workers. And I was wondering about the role of social workers in the greenhouse model, because it seems like it might be a little bit different than the traditional role. And then my other quick question was to ask if you're connected at all with the Essential Jobs, Essential Care New Jersey Coalition that's also working on issues with the direct care workforce in caring for older adults in New Jersey. It's New Jersey Advocates for Aging Well working with PHI on that, and I think it would be great to make that connection with them.
Sure. So I'm going to 100% throw this question to Rebecca, but I have, especially because of Rebecca's background as a social worker, but I do want to say a couple of things just before that, because the workforce is a really key area. So in the consulting work that I do today is largely focused on direct care workforce, the crisis, recruitment, and retention. All of the research around direct care workforce reads like an advertisement for the greenhouse model. So the three areas that impact recruitment and retention per research, and these are interactive. They can't be separated. They need to be addressed together. But it's compensation, which is wages and benefits. And the greenhouse model, since its inception, pushed for a 10% increase in wages for Shabazim because of the management and the skills they take on. Education and training. Direct care workers report that their job stress is enormously increased because they don't feel they have the training, appropriate level of training to take care of the very complex care needs that people have today in traditional nursing homes, greenhouses, et cetera. So the greenhouse adds, Rebecca, how many hours to the traditional training?
It adds about 120 hours additionally, yeah.
Yeah, and these are skills in communication, these are skills in managing their various household activities, this is in interpersonal relationships, so sort of a combination of care, but also operating in business, cooking, as Rebecca mentioned. And then the third big area in the direct care crisis, and I think any of us who have either worked in a direct care job or watched direct care workers understand this. Direct care workers report that their stress is also very much increased and drives them out of the workforce because they are not valued and they're not included in leadership and management decisions in their traditional nursing homes. And we talked a little bit earlier about the names that people are called. And I thought, to me, when I was at the greenhouse, one of the most meaningful moments was when you walked into a traditional nursing home that was transitioning to a greenhouse, and you would go around the room to start the training with the CNAs, and you would ask people to say what their position was and a little bit about themselves. And I would say 90% of the time when a CNA introduced herself, and it was mostly her, she would say these exact words: "I am just a CNA." But when you went back a year later and you said, "Please introduce yourselves," there was not one person who said, "I am just a Shabazz," because they knew that the model valued them and empowered them and gave them a role in the leadership. So the value and the resources that greenhouse and small house and culture change models put toward the direct care worker is a key to solving the direct care workforce shortage. So let me turn the question over to Rebecca.
Well said. Shabazim are the star of the home. So when you don't have family, they come into that role in all of the good ways family come into it and leave all the stuff that we don't want to bring into it out. For social workers or activities leaders, the way that it's a tough pill to swallow for people who go into long-term care in order to perpetuate a system. And as a social worker, there's nothing more vile to me than going in and perpetuating a system that harms people. It was always a difficult place to be, and as a social worker in a traditional organization, going, my whole job is to help people navigate something really terribly broken, and that's not uncommon in that field. What I love about the greenhouse model is it takes the strengths of social work, it takes the strengths of dietitians, it takes the strengths of activities staff, and it says, we want you to nurture the entity that is supporting that elder. So it's a systems theory, and you're really focusing your energy on growing the system around the elder into a healthy system that supports their goals, their individually expressed goals, desires, and needs. So a lot more of your effort as a social worker is spent working with direct care staff, not working with an elder. It's akin to a home care model or a care coordination model in IDDD, except it really has great, rich outcomes that a social worker who really cares about community health could really benefit from. If you are really invested in one-on-one time with elders, it's a tougher model for social worker activity staff.
Thank you, Rebecca. I would like to make one general comment, which I should have made at the very beginning. When I was working with nursing home providers who were adopting the greenhouse and also talking to other nursing home providers who were thinking about the greenhouse, what I saw was a group of people who were hungry for a way to deliver the quality of care that they came into their jobs and into their profession to do. But they felt hamstrung, not necessarily by the regulations, because we know greenhouses operate within the same regulations, but they felt hamstrung by the system they knew and the system they had been raised in. And one of the pieces that we have to work really hard around, I think, is to appreciate the hard work that direct care staff, nurses, administrators, and leaders have put into trying to make what is now a broken tool work, acknowledge that, value that, and help them find the courage to move into what is unknown in an environment that they have experienced as fairly punitive when they try to change something for the better. So that is, I think, on us from a policy perspective to make that work in a partnership model rather than in a gotcha model. And that's going to be a transition for everybody. So.
I think that's probably a good place to end. Do you have time for one more?
Sorry, two very quick questions, hopefully. The first has to do with the ownership of these facilities and just kind of what that looks like, if it's similar to the traditional long-term care space where it's predominantly for-profit, and if it's experienced the same type of turnover that we see in the more traditional space. And then more from a quality measurement perspective, just with the different model and the different processes in place, have you had to make adjustments in how you're measuring the processes within the homes from a quality perspective to be able to compare it to kind of the quality outcomes and processes in a traditional facility or setting?
Sure. Great questions, and I'm going to ask Rebecca to follow up since she's more familiar with the clinical side. I'm sort of the scale and finance guy, not so interesting. Rebecca's more clinical and great stories. So what I will tell you from the time that I spent, particularly with licensing staff at the state level, so we collect all the same information. We fill in all the same sort of data sheets. So we, from a quality tracking and reporting, we do much of the same work. We probably have a little better information because the direct care staff know that resident so much better. They can help the nurses who are filling out those forms really get to the bottom. They also can identify change more rapidly, so a change in condition. So they're not assessing, but they can certainly go to the nurse and say, I think Mrs. Smith is slower today. Maybe she has a UTI. Could you please come and give her an exam? But where the quality piece does differ is exactly what I was saying. You have a more intimate knowledge of those individuals. You can track them better. You can report more fully, and you can get clinicians involved more quickly. And that's where we see the outcomes, care outcomes, being better. And then the second part of your question was, tracking. So it's really through the same forms. The nurses are involved in the same way that they're involved with a traditional nursing home. And then as far as the ownership, and I'm guessing, Rebecca, this is still true. When I was involved in the program, we had 50 organizations that had adopted the greenhouse model. We had one of those 50 that was for-profit. So we're exactly the opposite of traditional ownership. To succeed, though, and to scale, we have to get for-profit nursing homes to see this model as in their interests to implement. And I think that's around not only the rate add-on, but certainly the regulatory support to make the transition. Rebecca, what would you add to that?
I don't think I need to add anything. From a quality standpoint, the QMs in greenhouse homes surpass traditional organizations by far in terms of falls, weight loss, ADL growth. All those things are measured. Depressive symptoms are higher because people are more well-known, we suspect. And polypharmacy is something that over the last couple of years we've seen creep. So we're trying to, but I suspect if you looked at any of our own houses, you might see the same. So I think we're trying to get a handle on those things. But that's where that annual database and that annual evaluatory process that comes with working with the project, I think is so valuable because quickly you can get a sense for where you're straying and bring your organization back. Whereas if you're not connected, you're kind of out there blind, you know. So.
I wonder if we could give the last word to Laurie as an ombudsman for your reactions to the model, especially around helping providers in the transition period when things are a little scary and new.
Well, I think you saw me nodding. I think I saw some of the provider groups nodding as well, that you have to give some grace to the people who have been doing this. And so my thoughts as an ombudsman, obviously the resident experience is paramount, right? We're resident driven, and clearly the resident experience here is incredible. The looking for meaningfulness in their lives is not something that you think about a lot when you're in a nursing home. And so I think that we do have to recognize that as a system, we do need to, the current system will come in and just slam a nursing home for something. And so the fact that they maybe are reluctant to change is understandable, because you can see that this is how we do it, this is how we prepare for survey, this is how we align with what we see as the regulations. And I think that there's a lot of fear. And so I think we as state officials, legislators, the Commissioner of Health left, but regulators need to recognize that they're operating out of a place of fear. So we need to kind of create that space and some running room for innovation in a way that I'm not sure that we have done previously. But from a resident experience perspective, this is the way to go.